So, good afternoon. Today, the topic is ocular injuries. Let me share the slides. Kindly acknowledge me whether the slides are visible. Is it visible?
Yes, ma'am, it's visible.
And is it up to full screen?
Yes, full screen.
Full screen. Okay. So, is it mobile? Moving?
Yes, ma'am. Yes, ma'am.
Okay, good to go then. Okay. So let us start the topic of ocular injuries today, right? As we know, ocular injuries, we have mechanical and non-mechanical. So today, because of time constraints, we will stop short with the mechanical injuries. Non-mechanical injuries, we have chemical, thermal, electrical, radiational injuries. We will keep it at the next session. As in the mechanical injuries, another classification, we have extraocular foreign bodies and blunt trauma. Extraocular foreign bodies are those dust particles which can be anything like hay dust or iron dust particles, whichever has been when you drive, anything can come into your eyes, and we will deal with that, how to tackle and how to treat it subsequently in the slides. And in the blunt trauma, we have closed globe injury and open globe injury. So out of this closed globe injury, it is meant that the ocular coat is not broken. So it is not penetrated. So that is what it means. In open globe injury, you have a through and through wound in the ocular coat, ocular eyeball. So that is what it means. So under the closed globe injury, you have simple contusion or partial thickness, that is lamellar lacerations is brought under it. In open globe injury, you have globe rupture and laceration, which is penetrating, perforating with retained intraocular foreign bodies. So there is a difference between penetrating and perforating. So what is penetrating is that any sharp object which enters into the eyeball and is being taken out through the same wound. That is, only one wound will be present. So when it is coming to perforating, you have entry wound and as well as exit wound. So that is, you can imagine a bullet shot. So there will be an entry point in the eyeball as well as the exit point through the other side. So that is the perforating injury. Okay. So now coming to the extraocular foreign bodies, the palpebral fissure as we open, so that is the commonest site in the either conjunctiva or the cornea. So the common type would be, it is paddy husks or iron, emery coal, any particles, glass, wood, wherever you get injured, anything can be there. So if these particles are there, which is dust, hay, those things, because of your lacrimation and watering, it will be relieved mostly. But the commonest site which is getting lodged usually in the subtarsal sulcus, as you see here, right? So in this case, if it is such kinds, you are supposed to remove the foreign body. So never, whenever any patient comes with the history of foreign body with redness and irritation, kindly avert the lids and see, find out if you could find any foreign body as such here. Okay, so and you are supposed to remove. Without removing, this subtarsal sulcus foreign body never goes out, right? So the complaints will be as such pain, irritation, watering, and discomfort. So the signs would be, definitely they will not be able to open the lids because of the blepharospasm and congestion will be there. So accordingly, this picture shows the corneal foreign body. So this is usually, those people who are in the welding works and they tend to have commonly having such kind of corneal foreign because the fast moving and particles, they just lodge onto the cornea. So this is, are we supposed to remove these foreign bodies under the slit lamp? Right, slit lamp examination, we first need to see how much depth the foreign body is there on the cornea. So if it is very deep, it is good to remove the foreign body under the microscope in a sterile setup. Right. So if you are not able to remove, and this will be the complications. Usually it is infection, that is bacterial conjunctivitis can happen. In cornea, you can have the corneal ulcer, which is happening, and corneal pigmentation and opacity follows. So with using this, we used to remove the corneal foreign body using the 26 gauge needle. And as I said, if it is deeper enough, you are supposed to remove it under a sterile condition. And after removing, antibiotic eye drops, and then with pad and bandage, usually we don't do, right? So because when you pack a pad and bandage, that again because of the nidus of infection. So we leave it aside and ask them to apply antibiotic eye drops. And if it is deep enough, they should be report us within 3 days. So we are supposed to see how far it is healing. And one thing I wanted to make sure that everybody knows is that ophthalmia nodosa. And this is the reaction of the caterpillar hair. So which is common in our areas, because these caterpillars during the seasonal changes, when you usually in the trees, drumstick tree most commonly, and our people comes with irritation. And here, when it happens, you see this pattern aberration. So whenever they come with some foreign body fall and you see such kind of patterns on the cornea, you are supposed to fix in your mind that here where is the injury, and you have to have some foreign body relevant to the conjunctiva, palpebral conjunctiva, with that site of the cornea. So accordingly, you have to evert if it is upper lid, or in the lower lid, you have to open the lower palpebral conjunctiva and find out, are we looking at any such kind of caterpillar hair there? And if you don't remove, definitely they are going to be exciting a severe iridocyclitis granulomatous. That is why it is called as ophthalmia nodosa. Okay. So now coming to the blunt injury. So the effect of blunt injury usually, either the fist or cricket ball or blunt weapon. So these are all should be more than the size of the orbiter. So only then it can cause a blunt injury. Okay. So when this happens, when the injury happens, depending upon the force as it has been applied over the eyeball, the cornea deforms and the aqueous has been pushed back, and that is where the fluids, vitreous and all been pushed, and then they could come back. So this waves, compression wave bounds, and because of this, you get to have this injuries, and because of this, you get the laceration, partial thickness laceration, which is happening. Right. And because of it, the first and foremost, anteriorly, you can see the ecchymosis, which we call it as a black eye. Okay. So apart from this black eye, you can have partial thickness lacerations of the lid, which has to be sutured subsequently. And because of the swelling on the ecchymosis, you can have ptosis of the lids. And this example, you have the panda eyes, so this is the darkening, both ecchymosis, and this you are supposed to see. And this is the partial thickness laceration, and which has to be sutured depending upon the depth of the injury. And this is again the laceration, which has to be sutured as well. And subsequently, we have the orbital wall fractures. Excuse me for a minute. Okay. So as you can see, the inferior orbital wall is broken here and the tissues are being hanging up. So this is the hanging drop sign in the CT. Okay. As you can see in this picture, the inferior orbital wall is fractured and the tissues has been incarcerated into the fracture. And this kid, has been injured and he's not able to move his eyes upwards. So this is the injured eye, and this clearly shown that the superior elevation is restricted. Okay. So now coming to the lacrimal apparatus. So how you have to deal with this is that it's, if at all you find such kinds of elevation restriction, definitely the patient will have double vision, diplopia. So this is the one of the reason for intervention. So as you have to intervene, you have a surgical intervention to remove the content from the maxillary sinus, and you have to keep a plate depending upon the size of the fractured area. You are supposed to keep a plate and suture with the periosteum. Okay, repair of the orbital floor has to be done in such cases. Coming to lacrimal apparatus injury, any injury which is happening medially injures the canthus also. So as you can see, you have a punctum, and so here you can see the punctum, right? Very, very, if it is magnified. So all the canalicular injury, any medial lead injury has to be examined properly under microscope to find out whether there is any canalicular injury. If you don't examine properly and just the lid suture, if you suture it up, then constantly the patient will be having a watering when the throughout their patient's life. Okay, so because primarily when you suture, you have to see what has been injured and it has to be repaired. So when there is any canalicular injury, we use a prolin. So we insert through the punctum and we repair the canalicular part, and it is closely opposed. And finally, we remove the prolin suture material, which is through the canalicular passage, maybe after a week or so. So the end will be approximated over the skin side to prevent any corneal injury also. So this has to be followed closely, and post-operatively we give a steroids as well to prevent any inflammation and scarring of the canalicular injury. So that's how it is very, very important to notice any canalicular injury and has to be repaired properly then and there when there is a primary suturing is been uh, done. Okay. Sometimes you can have a lacrimal gland dislocation during injury. Now coming to the conjunctiva. As in the conjunctiva, everyone must have noticed such kind of subconjunctival hemorrhage, which is there. So here you can notice the subconjunctival hemorrhage and chemosis, so edema of the conjunctiva. Here, the striking point is that the posterior limit of the subconjunctival hemorrhage is not seen. So it implies that the hemorrhage, the reason for hemorrhage might not be local. It can be either wall fracture, orbital superior wall fracture, or it can be a retrobulbar hemorrhage. That's how you have to think in that terms. So that is where the posterior limit of SCH is very important in documenting. Right. So coming to the last aspect in the subconjunctival hemorrhage, the treatment part is usually, hemorrhages resolves on its own in a 2 weeks to 3 weeks interval. Right. You have to give, if there is any irritation, any other complaints, you have to treat that. And prophylactically, to prevent any infection, you can give a course of antibiotic drugs for a week or 10 days. Right. Now coming to the laceration, such kind of laceration, minimal laceration in the conjunctiva can be left if it is in the peripheries can be left without any suturing. If it is larger, suturing is needed because conjunctiva is highly mitotic. It might heal on its own in a couple of days. Right. So coming to the corneal injuries. So as in the corneal injuries, as we have seen earlier, pattern abrasion, you can have abrasion, but without any foreign bodies present. So as you can see, the foreign body might have been dislodged because of the lacrimation. So only the abrasion can be seen. Depending upon the depth of the involvement, you can have corneal opacity on healing. So only when the epithelium is involved, you will not have any opacification because the epithelium is highly mitotic and it can cover within a day, depending upon the size of the epithelial loss. Okay. So if it is 2 to 3 millimeter loss of epithelium, it can be regenerated or renewed within a day. If it is more than 6 or 7 mm of the epithelial loss, then it has to be in a couple of days. Right. So, and surgically also, we sometimes remove the epithelium for various purpose, like in C3R, where we have a cross-linking because of the keratoconus, we remove the epithelium and subjects the cornea. So in such cases, it renews back in maybe 2 to 3 days interval. Okay. So now coming to the laceration part. So you can have a partial corneal laceration for which the corneal suturing has to be done. So here where you can see in the picture, there is a lacerated corneal wound for which the sutures has been done. So now coming to the sclera. So as these are all under the blunt injury, sclera can also have a laceration. Usually the weakest part is near the canal of sclera. So this is the weakest part where it gives way. So this is again, you can see the uveal tissue also popping up through the through the damaged sclera. Okay, so you cannot call it as a rupture. So the rupture is the one which comes under the penetrating injury, where you have the forces from within and out. So that is where you call it as a globe rupture. So these external from external to interior, when there is a wound, then it comes as a laceration. So that's how we are supposed to address. So the rupture is when the force of damage which comes from within, inside the globe, where you have the fluids and other things, which exerts such an amount of force when the tear or the break of the ocular coat is happening from inside out. So that is called as rupture. Okay, now coming to the anterior chamber, you have collection of blood, which is called as hyphema. Okay. So depending upon the size of hyphema, the management differs. So this kind of such kind of 2 to 3 mm of height of hyphema presence, it can be resolved on its own. So within maybe a week or 10 days, so the blood can be absorbed. So you have to make a note of whether there is any inflammation, iritis is present or not, or when there is any, is there any presence of change in the intraocular pressure. So rise in the intraocular pressure, you need to have with the, that is secondary glaucoma, you need to add on with the anti-glaucoma medication. If there is any additional iritis or iridocyclitis, steroids can be as added for the treatment purpose. And when it happens, such kind of injuries, has to be followed up. So subsequently later, the all the patients has to be done, gonioscopy has to be done because of this force, whatever we see from within and out, the moving of the vitreous and aqueous, you can have a dialysis which is happening or angle which is recess, in the sense more of the ciliary body can be seen. So here in this picture you can see the usually, so as you can see the four structures in the angle. So the ciliary body band, which is more than the normally seen band. So this is the normal size which you are supposed to see. So here, this is where the angle has been recessed because of the injury. So here, this can be prone for a secondary glaucoma at a later date. Okay, so hence you are supposed to do a gonioscopy in any patient of a blunt injury. Okay, keep that in mind. And now coming to the iris. What are all the things can happen in the iris? Either it can be a traumatic midriosis or traumatic meiosis. You can have a sphincter tear, or you can have a iridodialysis or cyclodialysis, or you can have, as I said, inflammation can happen. So here, this is the iridodialysis is from the root of the iris is being torn from its attachment. And you can see the sphincter tear here in this picture. And because of it, you can see the blood in the anterior chamber. Okay, so these are all the changes. So if it is traumatic midriasis and meiosis, there is no such treatment. You have to wait, follow up the patient. Sphincter tear, again, you need not get in and suture sphincter. No, it is more obvious that you have to follow it up. So to find out whether how the patient, there is any trauma to iris, definitely there will be some kind of inflammation happening. So for which, if there is a iridocyclitis or iritis, then steroid treatment has to be continued for the patient along with the antibiotic coverage. Okay. So that is how the iris has been dealt with. Now coming to the lens, you have, this is called as a Washius ring. So this is when the force, because of it, the pupillary margin has been impinged on the lens and gets back. So the pigment of the pupillary margin gets stuck onto the lens, and this is called as Washius ring. Okay. So you can have the cataract. So because of the, which is called as rosette cataract, right? And you can have a total cataract like this, and you can have a subluxation also. You can see, the margin of the equator of the lens is already seen through the pupil, which should not be seen, right? In that case, you presume that the lens has been subluxated from its original position. So this rosette cataract, this is again a concussion cataract because of the mechanical effect, because lens capsule becomes injured and aqueous gets into the lens, and hence you have this accumulation of fluid. So which is usually is a star shaped around the cortical sutures. You have a Y-shaped suture lines, right? Front anterior vertical Y and inverted Y behind. So along all the margins of it, when it gets such kind of opacification, we call it as a traumatic and or rosette cataract. Okay. So this is a picture. Usually it appears in the posterior cortex. And again, when such kind of rosette cataract is there, you have to suspect the capsular integrity. right? You have to always be suspicious. You have to check whether the capsule is intact or not. Either you can do a anterior segment OCT to find out whether the integrity of, because during management the posterior capsule has to be intact for you to place the intraocular lens, right? If it is again already rent pre-operatively, then you are supposed to make yourself equipped with some secondary IOLs or some procedures or anterior vitrectomy. All these things has to be made ready during the surgical treatment for the cataract. So for this, you are supposed to suspect everything. You have to suspect, right? And then only then you can do a better treatment to the patient. So after initially, if there is any inflammation, you have to treat with steroids, and after the resolution of the inflammation, only then you can take for surgery. So now coming to the vitreous, you can have pigment deposits, I mean, in the opacities in the vitreous because of the trauma, or you can have this liquefaction of the vitreous, which can happen, or you can have a vitreous hemorrhage. So even this is again a picture of the vitreous hemorrhage. So if there is any vitreous hemorrhage, again you have to wait. As we have waited for subconjunctival hemorrhage, vitreous hemorrhage again you can wait for 2 to 3 months to find whether it is observed on its own. So another few other pictures of vitreous hemorrhage. This is subhyaloid hemorrhage. So behind the hyaloid, you have the collection of the blood, and that is called a subhyaloid hemorrhage. If this is affecting the macula, then you can use a laser to make a spot, so through which the blood is drained out. So that is what is a treatment for subhyaloid hemorrhage. So now coming to the choroid. So because of injury, you can have a choroidal tear, right? So in this case, because of the choroidal tear, you can see the white sclera through the retina, right? So because of this, usually, the color when you see the fundus, the pink or red, whatever you see, it is because of the choroid, which is highly vascular, right? Retina is a vascularized tissue, transparent tissue. Okay. So when there is any breakage in the choroid, again, similarly, because the vascularity is lost, hence you can see the white choroidal tear. So like this. So if it is through the macula, definitely it will affect the vision. So if it is peripherally, it might be unnoticed. Okay. So again, this is the initial picture where you have a hemorrhage also. After you can see the OCT picture where you have the collection of blood and you have a breakage in the choroid. So and subsequently, when it heals up, you have such kind of picture. You have a scar, and here there is a break in the choroid. And this is again a picture of a choroidal hemorrhage. And you can have a choroidal detachments also, like this. So the choroidal detachments, choroidales. So this sometimes you after hypotony in post glaucoma surgery, you have such kinds of choroidals happening. So this choroidal detachments again has to be followed up. There is no kind of surgical intervention for choroidal detachments. You have to wait and watch. Slowly it gets resolved on its own. And coming to the retina, you have edema of the retina, which specifically called as Berlin's edema, where you have the edema in the macula. So this like Berlin's edema, and you have a cherry red spot. So because you have a swelling in the ganglion cell layer, hence this is appearing as a white. So since because in the center fovea you don't have the ganglion cell layer, since the already existing color of the retina is still present, and hence it has been enhanced. Say we call it as a cherry red spot. There are other differential diagnoses of cherry red spot also, which you have to reel out. And you have this is the break in the retina. This is the retinal tear. So through which you have the vitreous liquefied entering in and causes a retinal detachments. Yeah, so retinal hemorrhage, macular edema, retinal detachment. These are all. This is again another picture of the Berlin's edema where you have a commotio retina. You can call it as commotio retina when there is retinal edema. And this is the central cherry red spot. Sometimes, because of the blunt injury, optic nerve sheath hemorrhage and also optic nerve, very rarely, this are all not often, avulsion of optic nerve also can happen. Now coming to the globe rupture, used to sudden violent force against the orbital wall, the sclera gives way from within and out. So usually again, the weak spot is the near the canal of skull. So here where you had a globe rupture. So it's how to deal with the what are the other findings in the globe rupture. This is either all the structures can be disorganized. So it is iridodialysis can happen. The lens can be either it can be dislocated into the vitreous, or it can be beneath the subconjunct. It can come. Some we have seen phacoseal we call. So lens coming into the not in the anterior chamber. It is through the injury. It has come under the subconjunctiva. Like it will somewhere look like a bleb. And after a careful anterior segment OCT, we found out that is the lens, and hence we intervened. So that is about that. And blood in the anterior chamber and vitreous hemorrhage can happen, retinal detachment, and ultimately, finally, the eye shrinks because of the ciliary body lost, and the aqueous production is also lost. Treatment, if it is very severe, the globe is not intact, then you are supposed to remove the structure, remove the globe. So it has to be removed to prevent, which what we call it as sympathetic ophthalmitis. When the iris and uveal tissue has been injured, it can initiate a hypersensitive reaction, and later the other seeing eye can also be injured in the process. So that is called as sympathetic ophthalmitis, for which any ruptured globe beyond repair has to be removed. Okay. So if it is less severe, eyeballs are intact, then you can suture and okay. So now coming to the penetrating injury, either it can be due to the defect of damage or mechanical effects, or because of the foreign bodies, and or because, as you can see here, sympathetic ophthalmitis is also there. So any of the whatever you have seen, it will be more severe in the penetrating injuries. So all these things, if it is any damage, you have to suture. Right. So another important thing you should notice, the infection which is introduced by any foreign body is highly difficult to treat. Right. Unless and until you find it in the initial phase. Otherwise, really the eye becomes refractory to any treatment. And finally, you have to do some measures, either if it is contained within the eye, then endophthalmitis, what we call, and you have to initially treat with intravitreal antibiotics. And if it is not subsiding, then core vitrectomy is a choice. If it is panophthalmitis, no other go, evisceration is the treatment of choice. Okay. So when you cannot save the eye. And if it is iridocyclitis post-traumatic, then as we know, steroids has to be put hold with the coverage of antibiotics. Okay. So again, now with for the short of time, we have intraocular foreign bodies, because any which can fall in anterior chamber, it can be there. In that case, you have to remove the foreign body. And because the foreign body, if it is iron foreign body, the reactions, the disintegrative particles of iron can get anywhere in the parts ocular structures. So it can come into the anterior lens, it can come into the iris, and you can get in the on the retina. So anything can happen, which we call it as collectively siderosis bulbi. So it is rusty deposits can happen in any part, and it can increase the intraocular pressure. Secondary glaucoma can happen. So these are all the various process and various structures where it can cause damage. It can cause damage to photoreceptors, which can be seen as a reduced electroretinogram response. So this is a picture of a siderosis, and you can see the deposition here. Okay. So, and how to prevent is the conioscopy, careful history, and treatment investigation is a must with CT, which can imaging study, and ultrasonography can help you. So if that is the case, you have to remove the foreign body at any cost. Okay. So this is about siderosis. There is another foreign body is chalcosis. So here you have iron foreign, copper foreign body. You have this Descemet's membrane deposition of copper, and which is called as KF ring, and you have the sunflower cataract. So these are all the features of it. You have to diagnose with imaging studies, and then so this is the picture of the foreign bodies which is present, and inside the eye, just past planar vitrectomy. We are trying to remove the foreign body. So I think depends upon where the foreign body is. Accordingly, you are supposed to remove the foreign. Another picture where it is with the vitrectomy, we are trying to remove the sheet of foreign body. Okay. So I think we ran out of time, and I stop here. So this is the take home picture is that any patients comes with any foreign body has to be thoroughly examined and it has to be treated accordingly. Okay. So we'll just stop the recording as well. Thank you.